And that's, I think it's hard. Mm. Wait, this is mouse? No. Just if you use this. There we go. So if I need to point at something, I gotta use this. It's okay. We'll see what we can do. So you Oh, wow. Okay. It's 11:03. I'm good. Can everybody hear me? No. Hello? Oh, no, no. Oh, no. Can you guys hear me okay? Yeah. Okay. An hour is a long time. What do you guys want to talk about? We're going to talk about stroke today. Thank you for coming, everybody. Thank you especially to everybody that came that didn't have to be here. Appreciate that. I kind of laughed when they sent out the flyer because I guess this is just called stroke. I guess I forgot to submit some sort of better title. The general framework for today was going to be to talk about different stroke syndromes based on vascular territory affected. It's kind of like that. I'm not real good with framework, so we'll see how closely I can stick to it. There's some objectives there. Um, Stroke is very near and dear to my heart, as it probably is for every neurologist. And the study of stroke really forms the bread and butter of neurology. Because for a long time, that was how you learned about what the brain did. People would have strokes occur, they would inevitably die, and maybe somebody would cut them open or dig up their corpse or whatever, and eventually figure out that there was a chunk of dead brain tissue. And it somehow correlated to whatever symptoms they experienced. So historically, it's been sort of the way to know what different parts of the brain generally do. Stroke's been a word that's been around forever, hundreds and hundreds of years. Apoplexy was a word that was more historically used. It's Greek and means something like to be struck down. So that's where the origin for stroke comes from. And it's a great word. When you want to recognize stroke symptoms, your mind should first go to sudden onset of focal neurological deficits. Key is sudden onset. All right. So if somebody has something gradually can't come on over several days or weeks, or if somebody's had some sort of chronic fluctuating thing, we're not thinking stroke. Stroke would not be top of mind. So with stroke being acute onset, sudden onset, I think the word stroke works really, really well. Couple disclaimers just throughout this. When I say the word stroke, I'm generally meaning ischemic stroke. If we were talking about hemorrhagic stroke, I'd probably say bleed or hemorrhagic stroke or something like that. So the two are basically synonymous for the purpose of this talk. I would encourage everyone to just don't say CVA or write CVA. It's kind of a pet peeve of mine. This is just my soapbox right here and now. Patients don't know what that means. It sounds very highfalutin. It sounds like we're using medical speak for the sake of using medical speak. Cerebrovascular is a word I love because when we talk about stroke, it's really a plumbing issue. So the fact that it's vascular, cerebrovascular makes perfect sense. But the whole accident thing, I mean, it's not an accident. It's not an oopsie. It's just kind of weird language. And you guys have probably heard me complain about how the word stroke is one syllable and CVA is three syllables. So, like, what are we even doing there? Stroke is a word that's worked for hundreds of years and preferred word for me. And then another pet peeve, but a really strong one, like an automatic failure of the rotation, would be using the word mini stroke. This has been historically used to refer to TIAs. Patients don't get this. Most doctors don't get this. Mini stroke does not mean miniature stroke. The patient's under the impression that they've had a small stroke. Mini stroke is synonymous with TIA. The T is transient. Your deficits are transient. The ischemia is transient. We get a picture, no stroke shows up, no stroke has occurred. So it just adds a lot of confusion. When a patient comes in saying that history of mini stroke in 2014, I don't know what that means, and I have to dig around and try to figure it out. And by the way, you can't disprove a negative. You can't prove a negative. You can't disprove a negative. You know what I mean? So you're going to have transient symptoms that go away. You're going to have no objective evidence on imaging findings. And anytime we don't have a good explanation for somebody's tingling they had in a thumb for 3 minutes, it probably wasn't a threatened stroke, but they might leave the hospital with a diagnosis of TIA because you can't disprove it. I like using the language threatened stroke. I think it talks more about what's happening there, kind of threatened ischemia, threatened brain injury. Why is the brain so susceptible to ischemic damage? Uh, Part of the reason is that it's highly metabolic. It's approximately 2% of your body's mass, but utilizes 20% of the body's glucose-derived energy. Take it to the bank. The internet told me that. I don't know how they determine that, but just know that it's very highly metabolic. These are some PET scan images, and as you probably know, with PET scans, they use tagged glucose and kind of see where it goes, and that would give you a correlation with the metabolic rate in those places. We're doing this to look for tumors, which are more metabolic relative to the tissue surrounding them. But the brain is so metabolic on PET images that you can't even draw any conclusions about brain tissue. So on these pictures you see here, the brain just looks incredibly high signal, let's say. And then you see the bladder, which is where the excess tracer is collecting, and the renal tubules. And then the heart is very metabolic, so you're going to see some uptake there. Thyroid tissue. But yeah, the brain, I mean, if we're getting a PET scan, it's not to look for metastatic brain issues. For that, we have to do MRI studies because everything's highly metabolic. You get it. So it's can be very prone to injury if its nourishment supply, if you will, gets cut off. Blood, oxygen, glucose. I put caffeine in there for you, Mark. Yeah. For even a short period of time. And people, unfortunately, and family members, unfortunately, learn the hard way when a cardiac arrest occurs. And you can have a cardiac arrest that's relatively brief, and they don't really sustain much in terms of other end organ damage. And yet there's irreversible injury to brain tissue. So all the time up in the ICU, after an event like that, we're looking at isolated brain injury and how they're going to recover from it or not recover from it. What are the different ways in which brain tissue can be rendered ischemic? There's actually a lot of ways. I think arterial occlusion is the obvious one. If you block off an artery, you're going to disrupt blood flow. For much of this, I like to think about that equation that you've probably all seen before, where the cerebral perfusion pressure is equal to the MAP minus the ICP. So this would be the arterial pressure pushing into the headspace, with the opposing force being the intracranial pressure that's already there. And you have to maintain a higher MAP than your ICP, or else you're going to have diffuse perfusion failure. So hypotension, well, if you lowered your mean arterial pressures, that could affect that equation in such a way that you get reduced cerebral perfusion. Low cardiac output's kind of along the same lines there. And then there are ways that increase ICP that would cause ischemia. This is what we're trying to avoid when we're trying to control ICP, intracranial pressure, excuse me. So a CSF outflow obstruction, this would be like, I don't know, some sort of herniation process that would instantaneously cause ICP to rise above MAP, and then you end up losing your cerebral perfusion pressure. Trauma and other edematous changes to brain tissue can do it. And then kind of just a piece of trivia, after subarachnoid hemorrhage, there's vasospasm that occurs. And this can be a double whammy because they get increased intracranial pressure, but also with the vasospasm that's going on, they're going to lose some of their mean arterial pressure on sort of a microscopic scale. So it's a very bad complication of that particular sort of thing. And then there's hypoxemia. So you're getting all the blood you need, but the blood itself is not carrying what it needs to, oxygen namely. Respiratory failure could do that, hypoxemia. And severe anemia, don't forget about that one. Steele syndromes are interesting, but they're not usually seen. Usually when we're talking about Steele syndromes, we're talking specifically to subclavian Steele. If you get an occluded subclavian artery proximal to the takeoff of the vertebral artery, then what you can get is if the limb that's usually receiving blood flow from that subclavian artery is demanding increased blood flow, doing something strenuous, that it might be pulling blood backwards through your vertebral artery and away from the posterior parts of your brain. And so that could cause temporary symptoms or outright ischemia in certain cases. And then venous outflow obstruction is one that we sometimes think about. This would be where arterially everything's fine. Your brain's getting all the blood it needs. Let's say there's a blockage in one of your major venous sinuses. And so you have a lot of pressure going in and not much drainage coming out. And that can cause stagnation of blood within the tissues itself. And then you get venous infarctions, which look quite different from arterial infarctions. If you block off an artery, you're going to starve all the tissue that's supplied by branches of that artery. It's pretty clear cut, fairly well delineated. Venous infarcts tend to be fainter, more nebulous on pictures. They don't follow nice vascular territories. They're often not thought of until there's pretty significant damage that's occurred. So that's all on the supply side. One interesting sort of aside here. So we just talked about ways of delivering oxygen, basically. Cyanide is an example of something where your cells can't utilize the oxygen they get. So it's a different mechanism than everything else there. Works on a mitochondrial scale. And I'll tell you, last week we had an unfortunate woman who had anoxic brain injury, but for whatever reason, her imaging studies kind of looked like carbon monoxide poisoning. I got to admit. And carbon monoxide poisoning on brain studies kind of looks like cyanide poisoning. So I had to do some reading on that. And I think I'm just telling you guys right now, if there's some sort of murder in the Tri-County area and it turns out to be cyanide, I'm going to get pinned because I've done a lot of Googling about cyanide here in the past week or so. If they get a hold of my internet search history, I'm done for. Um, yeah, this slide is brought to you by Dateline. Cyanide usually makes a special appearance in certain cases where medical or dental providers have a spouse that dies. My top listen podcast 3 years in a row. Highly recommend. We can classify ischemic stroke into several different broad categories, and we're going to kind of take it on a sort of like a large artery take today, and we're going to talk about what would happen if you blocked off one of your larger arteries. So our focus is going to kind of be here today, but usually when we see ischemic stroke, it's because of small vessel disease or cardioembolic cause, or sometimes large artery causes. This is called a TOAST criteria. It's been used forever, so a lot of times you're going to hear us talk about small vessel disease, and that's kind of where this language came from. And then within that other determined etiology, this tiny pie slice here, there's a whole bunch of stuff within that that's kind of interesting to think about. And sometimes, if you're on rotation, sometimes we'll bring this up on the differential, coagulopathy related to malignancy or related to some intrinsic blood disorder or drugs or other things. This would be a neat topic for another day, I suppose. And then one other thing I wanted to point out back on this is sort of how often we end up not knowing what caused stroke. It's something I've had to become comfortable with, but I mean, families and people who have had stroke aren't comfortable with that. But it's a large chunk of the time we don't know. And even when a person leaves the hospital, we're still under the investigative process sometimes. They're going home with cardiac event monitors. They might have additional outpatient studies looking at the heart. And we're just trying to make sure we're not leaving any stone unturned here. But end of the day, probably about a third of strokes, we don't end up knowing what caused them. So we're going to use brief clinical scenarios, very brief, just like a sentence, to explore stroke syndromes involving some of the major intracranial arteries. I am going to keep referring to these two pictures, so they make like 20 appearances throughout this. A good place to start, just in terms of talking about the circulation to the brain, is just broadly dividing it into anterior and posterior circulation, because I probably use these phrases, anterior circulation, posterior circulation, multiple times per day. It's very commonly talked about. The anterior circulation would be about 2/3 of the total blood flow to the brain. And this is delivered through the carotid system. So your common carotid split into your internal and your external carotids. External carotids, who cares? Internal carotids, very important. They so the branches into the internal and external. The internal carotid artery has no more branches until it gets within the skull. And then it does all sorts of stuff. So in this picture, just to kind of orient you, we would be sort of looking at the base of the brain. This would be the right internal carotid artery coming up into the screen. And then at its terminus, it's going to branch into the middle cerebral artery and the anterior cerebral artery. And then the same thing on the other side. And in the back part of the brain, we've got two vertebral arteries that come up and through the foramen magnum. And then they join into the basilar artery, and they're going to terminate as PCA arteries normally. And there's all sorts of normal variants with this. So everybody's built a little different. And we see all sorts of strange things on the CT angiography studies. But the PCOM is an artery that's usually there, posterior communicating artery. and it serves to connect the anterior circulation and the posterior circulation. And it's sort of our dividing line. It's not super important by itself, usually, but I tend to think of things broadly as anterior circulation and posterior circulation. The NIH stroke scale, you guys have probably all had some sort of familiarity with. I don't know if you've ever had to administer that. If you did, you might be assessing language function with little pictorial cards like are seen on top of the screen here. The NIH stroke scale is heavily, heavily biased towards anterior circulation strokes. So if you think about running through the list of those, relatively few of those points could come from posterior circulation issues. Anterior circulation are the things you're used to thinking about with stroke. When we used to tell people in the public, well, what do you look for? What are signs of stroke? We use things like fast, face, arms, speech, time. All those things are anterior circulation symptoms. So there's a lot of things that can get missed or not recognized as stroke. There have been sort of other things. I put this thing down here called Be Fast. So they've tried to incorporate some posterior circulation symptoms like maybe balance issues or visual symptoms. But still, when the general public thinks about symptoms of a stroke, like weakness or sensory loss or language dysfunction or facial droop or dysarthria, dysphagia, most of these are, well, take that back on the last two, but most of those initial ones I said are anterior circulation in origin. And so here's kind of how this is all laid out on the brain itself. I think this is a nice, pretty picture here over on the left side of your screen. Looking over at the right, you guys have probably all heard of the circle of Willis, and that's referring to this loop of arteries right here. And over here, you'll see that it's quite small in relation to the brain in its entirety. Pretty small, but there's a lot of important things that happen in around here. You got your optic chiasm here. You have your third cranial nerves here that run parallel with your PCOM arteries. So one of the times those PCOMs really matter is if somebody's got a third cranial neuropathy. We always try to make sure it's not because of a PCOM aneurysm that's compressing that nerve. And now you can very easily see why. The basilar artery terminates as the PCAs. This is just at the top of the anterior portion of the brainstem. And this is just under the mammillary bodies seen here. Don't say mammary bodies, but I mean, come on, look at them. So those sit right at the base of the brain proper. And then just anterior to that, you've got your pituitary stalk. So we got all sorts of important structures happening right down there, right around the circle of Willis. You can understand how an arterial rupture in that area would be just completely catastrophic or detrimental because it's going to spill blood not only around those structures, but through all the different sort of crevices around here. You can also see how many other cranial nerves have close relations with these arteries. So it's kind of weird, but a lot of times when somebody comes in with a cranial neuropathy, a lot of times we have to rule out things like aneurysm. So we're getting angiography studies, though it might not have much to do with what actually is going on. All right, so here's the first little tiny case. 72-year-old man, sudden onset, left hemi neglect, left facial weakness, left arm more so than leg weakness. This picture either represents a CT for maybe the next day the person came in or the person waited a day to come in. I mean, this is not how it would look initially. There's been some time between the event and the acquisition of this picture. But on the CT picture, you see a large area of hypodensity. Generally, you'd say this is out on the lateral surface of the right frontal lobe, right parieto-temporal area. And if you look over here at our sort of cheat sheet, you're going to see that that's MCA territory. This would be very clearly MCA territory. You're also seeing some hypodensity extend into the basal ganglia. And most of the basal ganglia, but not all, but most is supplied by little arteries called lenticulostriate arteries. LSA is what they call them on these pictures. And those are branches off. Those are tiny little branches that perforate off of the off the MCA for the most part. So this clinical picture fits very well with an MCA stroke. Right MCA territory stroke. The key finding I would generally say would be left upper extremity weakness more so than lower extremity weakness in general. We'll talk about why that is on the next slide. But certainly the patient's going to come in complaining of weakness. A patient doesn't come in saying, I'm neglecting. You know, so that's going to be what they latch onto. That's what the triage is going to latch onto in the emergency department. That's what everybody's going to latch onto. So the weakness is the key thing there. Sensory loss, yeah, maybe, yeah, probably. But the weakness is going to be the standout symptom. Initial imaging clues. So they're going to come through the doors immediately. Let's say this just happened. 10 minutes later, they come through the emergency department doors. Their first stop is going to be at the CT scanner. Well, why? It's not to see the stroke. So you can have a massive acute ischemic stroke, and for probably 12 hours or so, your brain tissue can look incredibly normal, like nothing happened. Then you're going to start to get some changes that develop. But they go straight to the CT machine to make sure they're not having a hemorrhagic stroke, just so we can initially rule that out. You might get something like a hyperdense right MCA sign. This is when you're actually, with a non-contrast head CT, visualizing thrombus within the artery. It looks bright. You can tell there's something in the artery. Where that kind of falls apart is in older individuals that usually have calcification of their arteries anyways. Like on a good day, their arteries might appear a little bright. And then early signs that there's a huge amount of ischemia might be sulcal effacement or loss of gray-white differentiation. These are subtle little findings that no one really hangs their hat on. You would go on with further imaging for their testing. So for most people, let's say you're right-handed, your dominant hemisphere is going to be on the left. Let's say you're left-handed, your dominant hemisphere, it's still probably going to be on the left. So in the non-dominant side, in the parietal area, that's what we'd be talking about affecting here. So the right parietal lobe, you could very well get neglect symptoms. And neglect is pretty difficult to tease out sometimes. How do you tell the difference between a visual hemi-neglect and an actual visual field cut? I don't have a great answer sometimes. How do you tell the difference between weakness on one side and neglect of one side? That can be hard to tease apart. But you would expect some neglect if the parietal lobe is largely involved. I decided I'm not going to try to pronounce those words. But right there where my cursor is, this, I'll try, fine. Anosognosia? I don't know. If I say it fast, it sounds good. Anosognosia would be like a lack of awareness, a lack of insight that there's a problem at all. And then somato, body, this would be like a lack of awareness of a body part. So sometimes you see that. In our most extreme neglect cases, we could have a person that doesn't realize that their own arm right in front of their face is their arm. They'll say, it's a representation of an arm. It's a cardboard cutout of an arm, but it's not my arm. They say weird stuff. And that would be a really dense, deep neglect. And then, plus or minus gaze preference to one side or the other. When you involve the frontal eye fields, on one side, your gaze can tend to be directed towards the opposite side. And then it's the opposite if they're seizing. If they were having a hemispheric seizure, excuse me, I said that backwards. So if you have, like, say, right frontal lobe damage that involves your frontal eye fields, you would look towards the right. You'd have a preference towards the right. And in the setting of a seizure, it's the exact opposite. Instead of a lack of activity, there's overactivity, and then your eyes tend to go away from the side of the deficit. The biggest thing to note is if they have big time weakness on one side of their body, there should be concern for this. All right, so why the arm more than the leg? You guys are probably aware of the homunculus, kind of a bodily, a model representation of how much of the cortex is dedicated to different parts of the body. If you look down, oops, there we go. If you look down here at the bottom, this little representation of the brain, this line between the pink and the purple, that would be your central sulcus, and that would be your dividing line between the frontal lobe and the parietal lobe. And your primary motor cortex sits here in the back part of the frontal lobe, and your primary sensory cortex sits here in the front part of the parietal lobe. And they've split this up here. I hope you guys can kind of figure out what this diagram represents. The important thing to note is that when you look at what parts of the brain are ultimately wired up to the legs, they are medial and actually dive down the center fold there. They're medial. And then upper extremities would be more lateral. So MCA territory is the more lateral portion of those lobes. So it's going to affect your face and your arms more so than your legs in most cases. A lot of other interesting things come because of this. This is pretty well mapped out. I think maybe 100 years ago, people thought the brain was really mapped out. This part of the brain does this. And the more we learn about it, we learn about these diffuse networks of neurons, and it's just not that simple of a picture. But on these primary motor and sensory cortices, it kind of is. You can have a person come in with just hand paralysis, and if you think it's cerebrovascular, you can guess exactly which wrinkle they're going to have ischemia show up on. It maps out really well. And there's probably a little bit of overlap because some funny things can happen in some cases. You guys have probably heard of phantom pain or phantom limb syndrome, that sort of thing, which really became a well-known thing back in the Civil War because they'd have a mangled limb and you're out there in the battlefield and you cut it off. You got a wound that won't heal, you cut it off. You got a hangnail, they probably cut your arm off too. I don't know. So there were tons of amputations done, lots of complications with phantom limb stuff, and that's when they started studying it. Uh, when I got into, so I think the TV show Scrubs is probably why I went to medical school. And then this book right here might be why I did neurology. This was a fascinating book by a guy called V.S. Ramachandran. And he's the guy behind mirror box experiments for phantom limbs, if you've ever heard about that sort of thing. You can get a lot of phantom pain from a phantom limb phenomena. You get a lot of pain in a limb that no longer exists. How do you treat that? How do you treat that? He did experiments with mirror boxes. This is kind of a representation of what goes on. This is an amputated limb. And if you have your eyes at a certain angle, you can basically trick your brain into thinking that both limbs are again present. And it seems to help with pain. So this is kind of a form of therapy for pain. There's something weird about neuroplasticity, and there's probably some overlap in some of the wiring up here because after an amputation, a lot of people report some miswiring. What this picture in the top right is trying to show you is a graphical representation of somebody who had a limb cut off, and then when you touch their upper part of their arm, they tell you, I can feel that in my pointer finger that no longer exists when you touch right there. So you can sort of map this out, and it seems to be some sort of miswiring. It's not really a coincidence that your missing arm could map out to your face or upper arm where they're closely aligned on the cortex. You wouldn't get like, oh, I touch my upper arm and I feel my foot that's gone. I mean, it's too far of distance apart on the cortex. So there's something about being nearby and some of the miswiring that can occur, especially with brain remodeling or neuroplasticity. He's still doing things, I think. When I was a third or fourth year medical student, I found his email address, like not his secretary, like his email address. And I wrote to him and I said, I'm a fan, but like not creepy or anything. And can I come rotate with you? And I got like two sentences back, no punctuation, no capital letters, but he said yes. And he's at University of California, San Diego. And the happy ending of the story would probably be that I went out there and changed my life. But I actually had run out of elective time, so I didn't do it. And I was broke and like this was in the days of trying to find a place to live on Craigslist. It's like 2 weeks in San Diego. What am I going to do? And it didn't work out. But yeah, highly recommend that book. Interesting stuff, or at least reading about some of that phantom limb issue. All right, so back to this. Just a reminder. So we were just talking about the right MCA syndrome. So let's just play a game where let's say you're an embolus and you're traveling through the bloodstream. How do we get up there? So what's sort of the path of blood flow to that part of the brain? You're going to come up through the neck, through the common carotid artery, then the internal carotid artery, and then at the terminus, if you're a little clot and you want to affect the right MCA, you're going to go down the MCA. And it goes out into this fissure here. The left MCA is better visualized on this side. Anything could happen then. I mean, let's say you're an embolus that's broken up into 100 little pieces. Maybe you get 100 little tiny bits of ischemia. Let's say there's something about your blood that makes it a little sticky. Maybe that process starts off and then that clot just propagates. And pretty soon it's expanded backwards until your whole MCA is blocked off. And then you better hope you're getting an embolectomy. You might have enough atherosclerotic disease in that artery itself that there was never any embolus to begin with, but you had an unstable plaque or just enough narrowing that eventually just kind of finished itself off. So there's a lot of ways to get this. We'll talk more about it, I think. Next case, 68-year-old woman with sudden right facial droop, aphasia, and right arm greater than leg weakness. I mean, again, when they're showing up to triage, all focus is going to be on the right-sided weakness and the language issues. Over here, this is a non-contrast head CT. And despite the use of no contrast, you can actually see part of the left MCA. This would be that hyperdense MCA sign. Put some contrast in there and get a CT angiography study, and you can see that there is an actual occlusion there. There's some flow more distally, must be from collaterals. And this is going to result in a lot of injured brain tissue. This would be an early CT scan. It's not so early that it looks completely normal, but you start to see some hypodensity develop in here. You can start to see some sulcal effacement over on this left side. You can see the wrinkles over here, and you're starting to lose them over here. And then instead of a gray-white differentiation, which on this slice doesn't show up very well on the good side, but over here you can tell that you're kind of unable to tell what is gray matter and what is white matter. So this fits a left MCA territory, so now we're on the opposite side of the brain. Large chunk of the volume of brain tissue. Key exam findings I already touched on. What else is there on this slide that's important? You might get gaze deviation if the frontal eye fields are affected. You might get some preference towards that affected brain side. This one's a double whammy in terms of functional recovery. What do I mean by that? Okay, if you have to choose which MCA to have a stroke in, if it's a coin flip, you better hope it lands on right MCA every time, because you'll be left with maybe severe weakness on the left side of your body. But the other side, the exact same thing happens in a mirror image fashion. You might have the same weakness on half your body, but now also the inability to communicate. So in terms of being a physical challenge, in terms of, say, caregivers, now it gets even harder, even harder. And then there's huge quality of life issues that surround this too. A lot of people feel like they could live a happy life if they were physically immobile. But if you lose the ability to communicate with others around you, huge quality of life issue. Most would argue it's a bigger deal than any sort of immobility they get from stroke. And then as a sort of aside here, if you affect enough brain tissue that it's clear that swelling is going to be a major issue, then we might call that what's traditionally been called a malignant stroke, like a malignant left MCA stroke is what is seen here. The injured tissue swells, not right away, but maximally over probably 3 to 5 days. And you're within the skull. So the only way you have to swell is to expand inward. This is going to compress other brain tissue. And obviously the skull is a rigid structure, but the other thing that a lot of people forget about is the falx, which is this fibrous ribbon of tissue that kind of looks like a mohawk that divides the two hemispheres. And it has a space underneath where the corpus callosum connects the two sides to each other. But once things swell enough, you're going to get herniation that starts to develop past these rigid points. So you can see the falx here, here. You can see the membrane that's between the two lateral ventricles right here. And then this is actually the left lateral ventricle, or what's left of it. It's completely smushed, completely effaced, we would say. And there's a significant mass effect with some midline shift here. So right about here, the falx ends, right about here, the falx ends, and then all the midline shift happens underneath that. That would be called transtentorial herniation. And you can only do that so much. The only other way out is down. So once you start to have downward pressure, you're going to get things like uncal herniation, and that's where you notice pupillary dilation. And then eventually your brainstem gets compressed, and your respiratory drive is no longer, and there's no coming back from that. Anyways, well, on that note, for some people who it's apparent this is going to happen to, this happens in slow motion. If we see enough ischemia like this, and by the way, this must be a younger person. There's not a lot of atrophy here. It's not like they have really deep wrinkles over on the other side. So especially with younger people who don't have a lot of atrophy, their headspace is filled with brain tissue. They don't have a lot of room to swell into. What you would do is preemptively have them set up for the surgeons to remove part of their skull, what's called a hemicraniectomy. So here this has been done, and you can see that the brain tissue itself is actually mushrooming outside of the head. That's intended, and quite frankly, it's life-saving. A lot of surgeries, are there any surgeons here? No, not really. A lot of surgeons would claim that what they do is life-saving. It is. But I mean, if you look at people that say for a horrible appendicitis end up for one reason or another not getting surgery, some of those people survive and do okay. But this is a case where it's like you either have surgery or you're dead. It's very clear. So this is very clearly life-saving. It's a very heroic sort of thing. And then the residents and the medical students get to come in the morning and palpate your head, and they're feeling your brain under just a little bit of skin. And eventually that will all sort of melt away, and they'll have a big pocket of emptiness and cephalomalacia this side of the head. There'll be a big sunken area on that side of their skull. And the surgeons will choose to go back and replace that piece of bone there, or use some sort of mesh or something rigid to put there. All right, so same sort of thing, but this time the other side. We came up through the internal carotid artery, go out to the left MCA here. Lots of branches that supply lots of brain tissue. If you affect this, you're affecting a lot of things downstream. Next, quick case. 55-year-old man with profound leg weakness and some possible personality change. Focus should be on the leg weakness. That's what everybody's going to notice initially. Here we've got a CT. It must not be hyperacute, but it's old enough that we do see some hypodensity that's developed here, paramedially, so along the midline. And this very clearly represents a left, or excuse me, a right ACA distribution, ischemic insult. You can see the ACAs, anterior cerebral arteries, form kind of this mohawk-shaped thing in the center part of the brain. Down here, we've got MRI images that happen later. This is diffusion restriction. And you can see on an MRI just how much more clearly this sort of thing shows up. I talked about lenticulostriates. They're depicted here. They feed the basal ganglia, these little tiny things, very fragile. There are some that are fed off of the anterior cerebral artery as well. So you can see some here. And by the way, if you hear us talk about like lacunar infarctions, lacunar strokes, we're usually talking about strokes that occur to little bits of brain tissue because of damage to those little tiny lenticulostriates. They're microscopic, they're fragile. If you have things like, if you're a smoker and you got high blood pressure and lipid issues, diabetes, they're going to get damaged. They're going to kind of gum themselves off at some point. You're going to get a little focus of ischemia right there where the damage occurred. All right, so ACA territory, key exam finding, leg predominant weakness. Um, I don't remember what's on the next slide. Oh yeah, okay, now I do. Um, The frontal lobes, nowadays, we pretty much recognize that there's a lot that goes on in the frontal lobes in terms of executive function and personality and some of these big picture sorts of things. It wasn't always known to be that way. You know, once they started to figure that out, that's when things like lobotomies started happening. You can damage a lot of frontal lobe tissue and not have a lot of stark deficits on exam, but you can affect somebody's personality or the way they act. So sometimes if you affect enough frontal lobe tissue, you will get things like a lack of motivation, just sort of a flat affect. That's why that's mentioned in here. It's not going to be something we talk about in the hospital. It's not going to be an acute thing. But as the dust settles, if there's been a lot of frontal lobe injury, family members might notice they just don't seem motivated anymore. You know, this is when therapy's trying to work with you and you have to lose weight and quit smoking and all this other stuff, and the cards are just stacked. They're not going to be motivated to do much of anything. Okay, so who's this? What? Paul Revere? Phineas Gage. How did you guys know that? You just know. Like we just all know, right? I don't know why we all know this. Yeah, this is Phineas Gage. Clues. There's something going on at the left side of his head. He's had some sort of trauma there. And he's holding the thing that went through his head. That's right, Stan. That's right. So that's Phineas Gage. He's a famous case. This is not stroke related at all. It's trauma related. But he's a famous case where people were like, how does he have this much brain injury? And he's generally okay without focal deficits. I mean, he's sitting upright. He's using both his arms. But he had big time personality changes. And this was because all the damage was anterior enough. So if you don't know, he's a railroad worker. They do something with these, I think they're called tamping rods or something like that. And he has to put gunpowder down in a hole, and this thing goes off. And it sends it flying upward, and it sends it flying upward right through the front part of his skull. And I think, yeah, here's a representation of what probably happened to him. And he changed big time, and he was studied, and he was kind of a marvel because in some ways he did so well, and in other ways he didn't. Okay, so last year, I went to Boston. I just walked around Boston, and one of the things I did is I checked out Harvard Medical School. They're not better than any of us. They're not. But there are certain days and certain hours where you can go into their library, Harvard Medical School library. Has anybody been there? You have? Daniel. And on the fifth floor, I think it's the fifth floor, the top floor of the library, they have a bunch of cool old medical collections. And I'm just wandering around up there, and wouldn't you know it, in a nondescript glass cabinet, they have the actual skull, his actual skull of Phineas Gage is on display right now, as far as I know. So you can see where the injury was up here. I mean, it kind of looks like somebody tried to do something with that and then was like, oh, this is overwhelming, and just kind of put things back in place and moved on. I don't know. I don't know what happened there. And they also have the actual thing. It's there. So if you get a chance, visit, see the man himself. What's left of it. Oh, sorry. So if we're the hypothetical embolist, we're coming up through the same route, carotid system, internal carotid. At its terminus, this time you'd go through the anterior cerebral artery. There's a lot of variance with this. Sometimes there's an anterior communicating artery, sometimes there's not. In really weird cases, uh, maybe the anterior cerebral artery shares a supply from one side of the brain, and that's interesting. But in general, it's kind of staying just along the midline section of the brain. And that's why the brain tissue it affects is more along the midline. Moving along, 64-year-old woman, sudden onset right visual field loss and mild confusion. Mild confusion, nobody's going to latch onto that. Triage is going to talk about visual field loss. Maybe, maybe. We'll talk about that more in a minute. But on this scan here, this is pretty obvious. This is an MRI. I think it's a diffusion weighted image. And yeah, it is. And there is ischemia in a very distinct pattern throughout most of the PCA territory. And most learners will recognize that the PCA, posterior cerebral artery, goes to your occipital lobes. It also goes to the medial part of the temporal lobe and the thalamus, this sort of football-shaped structure here. And sure enough, on this person, there is some thalamic involvement too. So that's kind of a nice fit for a PCA territory. And it looks like a PCA, posterior cerebral artery got occluded for this person. This is the right side of the brain, which would cause visual field deficits on the left, which I think I talk about here. So the typical finding here would be a homonymous hemianopia. They lose half of their vision of each eye. There's a lot of confusion about this too. Me, the neurologist, I really only care about binocular anything. If there's a monocular issue, for the most part, it seems like it'd be an eye doctor's problem. So it's got to be something that involves both eyes. And then it has to kind of mirror itself on each side. I got pictures I'll show you. But just keep in mind that the PCA is generally notorious for causing occipital lobe ischemia, but it can do more than that. There's the medial part of the temporal lobe and the thalamus. And if you involve the thalamus, you can get a lot of sensory symptoms. You could get maybe a little bit of motor symptom, maybe even a little bit of aphasia. There's a thing called thalamic aphasia. So it can be quite a mixed picture. Okay, you guys love this stuff. I know you love this stuff. Albert, where you at? Albert, I never answered your question yesterday. Yesterday, he asked me something about why I check the visual fields the way I do, and then I think I got on a tangent, which sounds right. And I forgot to answer his actual question. Me, the neurologist, all the pathology that I'm used to dealing with happens to be retrochiasmatic. So if you look at this diagram, this where A is, that would be a lesion of the optic nerve. Yes, that's a neurology thing. That's also an ophthalmology thing. That would be a monocular visual issue, which would kind of steer you down a monocular vision problem in the first place. For everything else, it's generally homonymous, meaning that, so here's the chiasm. Chiasm issues we generally just associate with a mass in the area. So that could be usually a pituitary macroadenoma, something that's putting pressure on the chiasm, sometimes like a cavernous sinus process if you're really in bad shape. But that's very uncommon. So common ways to get this visual pathway interrupted would be retrochiasmatic. And whenever you do so, you're going to see that each eye's visual field is going to be affected in the same way. So it's homonymous. So this is why when I go to a patient and I'm just screening for any visual field deficits, I have both their eyes open and I just test visual fields. And by the way, visual field testing, you're not trying to test the limits of the periphery. You don't need to be way out here. These patients will generally have macular sparing, which is depicted down here in F. So when they're looking straight at something, they can see all of that central part of their visual focus. But you don't have to get too far outside of that before they lose everything. So, you can just kind of be a little bit wider than shoulder width apart. You don't have to be way out here. And very rarely will I have them cover one eye and cover the other unless I think there's something to that. But in general, this should all be homonymous. It should be same with both eyes open. Okay, so the way that this could be depicted, this could be a homonymous hemianopia. If you're looking out through somebody's eyes, and oh my gosh, the right side is missing. This is a right homonymous hemianopia. And by the way, hemianopia or hemianopsia, both are acceptable. I checked. Okay. But, so this is what you think a person might be seeing. This might be a visual representation of what somebody might be seeing. And I think it's inaccurate. The truth here is that most of these people won't even realize there's a visual problem. Most. Our brain does such a good job of filling in the empty space when we lose something, especially acutely, that we don't even realize something has happened. Keep in mind, too, that most of these people will have some macular sparing. So if they're looking straight at something, they can see it, they can read. It's just out in their near periphery where things are a problem. When we test bedside, we're testing with finger counting, that sort of thing. A more accurate way to test would be with a specialized piece of equipment called a Humphrey visual field test. This is why these patients go and follow up with their eye doctor, even though this is a brain problem. And they can map out much more clearly. This would be a very dense homonymous hemianopia. And then there's also these. These are your physiologic blind spots. So everybody in this room has a blind spot where the optic nerve attaches to the retina in the back. Not a single one of you is consciously aware of it. So your brain does a good job of filling in empty space, and sometimes it does too good of a job. So let's see, who's this guy down here? George Washington? Did you say George Washington? No. Oh, okay. All right. No, it's Benet, Charles Benet. It says so on the wall behind his head. Come on. So Charles Bonnet syndrome, you've probably heard of that. That's where you get really fanciful hallucinations in the setting of visual loss. This is not unique to just my sort of visual loss. If somebody has like macular degeneration, for example, a lot of times they can start to get hallucinations. Your brain is trying to fill in the blank space and it gets a little overly creative. And characteristically, these are very well-formed hallucinations. So it's not, oh, I saw a shadow on the floor and I looked over there and it vanished. No, they can tell you the details of if they're seeing people, what they're wearing, if it's an animal, what color was the fur. They're detailed. And that's what this is representing here. Somebody's artistic representation of uh, whatever they're hallucinating. At least in this graphical representation, whatever they're hallucinating occupies both visual fields. So I would guess that this is somebody that maybe had macular degeneration or something else. You'll find that with our stroke patients, a lot of times it's on one side, or it should universally be that they're having the hallucinations on one side where their brain is getting overly creative. So depending on where it is in the brain and where they're situated in the room, a lot of these people will report seeing things in the hallway that didn't really happen or seeing things out the window that didn't really happen. It just kind of depends on which side is affected. Uh, if you want to get away from eponyms and don't want to say Charles Bonnet syndrome, visual release phenomena or visual release hallucinations is what they're called. And for some reason, if you're going to see well-formed people, they tend to be smaller than actual size. And so classically, these were called Lilliputian hallucinations after Gulliver's Travels, which were depicted here. And if you ask, you'll be surprised with how common these are. A lot of times people don't want to volunteer this information, but if you ask, do you find that you're kind of seeing things that don't end up being there? You'll get a lot of yeses. All right, so if you're a little embolus, let's say you're traveling up through the vertebral arteries, which one? Don't know, doesn't matter, because those join together at the basilar artery, and then at the terminus of the basilar artery, it's going to divide into your posterior cerebral arteries in people with normal sorts of vascular anatomy. One of my favorite vascular anatomical variants is a fetal PCA. I don't know why it's called that, but if you look at this picture with me, imagine that the end of the basilar artery is right here. So it has ended, and then you're supposed to split into two posterior cerebral arteries. And right here where the cursor is, we have split into a left PCA. And here, this looks like a right PCA, but where's it coming from? Not the tip of the basilar artery. It actually stems off of the anterior circulation. So it's called a fetal PCA. Why is that important? Look at this picture down here. You might feel like when you see this, you recognize, there's some anterior circulation ischemia and some posterior circulation ischemia. This must be embolic. We should look at the heart. We should look at the aorta. We should check for a PFO. We should look for a DVT. I don't know, whatever. But if you find that they have a fetal PCA, this could very well be a carotid issue. So you could have a carotid problem that just downstream of that causes anterior and posterior circulation deficits. So it's very important to recognize. I know you guys are impressed with my image manipulation skills here, but this is sort of what's going on here. The PCA actually is fed from the anterior part. Oops. And there's just nothing that comes off of one side. That's what I tried to depict there. Next case, 59-year-old man found with quadriparesis, quadri four, all limbs, paresis, weakness, plegia, paralysis. So if you're severely weak, you're still paretic. Once you're completely paralyzed, you're plegic. So quadriparesis, weak in all limbs, severe dysarthria, decreased levels of consciousness. Oh gosh. Uh, this is a flare. No, this is a T2 sequence. Oh, T2 flare. Yeah, it says right there. So T2 flare, and you see some edema throughout the pons. That'll be a very bad thing to see. Here's bright hyper intensity on a diffusion weighted image of an MRI. Very horrible thing to see. The pons in its entirety seems to have been affected by something. Over here, we've got a graph, a 3D representation of what's going on with the vasculature. There's a very faint vertebral artery here. There's a very faint vertebral artery here. And you know those should join together to form a basilar artery right here, and it's not there. It's not there. So this would be a mass, I mean, it's a big pontine stroke. Basilar arterial territory. Um, at its worst, and certainly with the pictures I showed you here, I would expect a locked-in syndrome. Most people have heard of that. The brainstem is relatively small in size, and if you think about it, everything that happens in your brain to get to the rest of the body has to go through there. So sometimes it doesn't take a large lesion to cause massive deficits. And if you take out the entirety of your pons, you're taking out your outflow tracts to your body, and you're also taking out a lot of cranial nerves. So you will be, the lights are on, but you're not moving. You're awake, conscious. You have no way to speak, no way to move your limbs, and in some ways, no way to communicate, and in other ways, very rudimentary ways, or in other times, other very, very rudimentary ways of communicating. This is a nightmare. And the pearls down here, it says posterior circulation strokes can be subtle early. What I mean by that is it happens, but I don't think usually people present with locked-in syndrome. Usually these are people that are here and we know they have some sort of posterior circulation ischemia. Maybe we've even seen some basilar artery thrombosis, but we can't do anything about it. And nurses go in to do a neuro check and find that they're not moving anything. And it's just progressed. So usually there's some semblance that something's going on. We see probably, it's been a while, thank goodness, but we probably see one of these a year here at Firelands, I would say. Uh-oh. Sorry. There's a movie about, so there's a guy that had this happen famously. He was the editor of some magazine. This was a traumatic kind of car accident, and he became locked in, but he still had a little bit of blinking power left. And he was already, I think he had already been given money to write a book, so he went through with it. And he had a speech therapist that basically they came up with some sort of Morse code-like system where she would count blinks. And it took a long time, but they wrote a book. And then eventually this got turned into a movie. It's a good movie. It's a French movie. Got to have subtitles on. Um, and this is about locked-in syndrome. Another recommendation for you guys, if you have like a car trip or something, you're looking for a podcast series. This was pretty good. It's called Blink. This guy's a good storyteller. It's definitely not something you want to have kids around for if you're listening to. And I think it's like 10 episodes or something. It could have been four, but it's like 10 episodes. This was a guy that had his brainstem affected, all the entirety of his pons, by an inflammatory reaction to heroin. So this sort of leukoencephalopathy, the toxic leukoencephalopathy thing. So it's different. And long story short, he had good recovery, decent recovery. Whereas if it's from an ischemic cause, generally there's no recovery expected. So this would be the culprit here. Now, it's not uncommon at all. I would say it is common for people to have pontine strokes. We see pontine strokes quite a bit. Lacunar, little pontine strokes, because of damage of these little tiny perforating arteries into the pons. And people can look generally good after that happens. They can have weakness, they can have bad symptoms, they can get away with it, but it's not locked in because you're only affecting a tiny part of the pons. So if you affect all those perforators, it really means you're affecting the basilar artery right here. And if you get thrombus in there, it's not a good situation. We are not to the point where any endovascular surgeon is going in and trying to retrieve clot from there. Sometimes they do it. It's been studied. There's a lot of complication rates with it. If somebody gets shipped to Toledo for large vessel occlusion, they're getting shipped there probably for MCA or something more anterior. Most times they won't try anything here posteriorly. There's too much to lose when a complication occurs. Someday. Oh, geez, I talk too much, guys. Oh my gosh. Vertebral artery stroke. Do you remember how in the pictures you have two vertebral arteries that turn into one basilar artery? So that's the great equalizer. If you have a problem with any vertebral artery, you can get bilateral issues superior to that. So you can get a grab bag of posterior circulation symptoms. It's kind of hard to predict how these people will present. Um, and it can be caused by trauma. That's why I put that picture there. Old cars didn't always have headrests. You get a lot of whiplash injuries. You get a lot of vertebral artery injury. Um, Here's an old-timey picture that I find beautiful. Here's a vertebral artery going up through the spinal column, through the vertebral foramina on each level. So a key thing to know is that the vertebral artery is encased in bone through much of its course. And this puts it at particular risk for shear injury, like whiplash injury. And then, I don't know, there's somehow a picture of A.T. Still and the founder of chiropractic medicine on the slide. I don't know why. I don't know how this got there. But vertebral artery dissection can cause this as well. You get a false lumen, as depicted here. You get blood that sits stagnant in here, and it forms clot. And then as the clot exposes itself to that surface, you get clot that propagates until it's big enough that it gets broken off and goes downstream. Uh, the lining of your artery has a nerve supply. So vertebral artery dissections tend to hurt. People will complain of pain that starts in the neck and radiates up into the back of the head. If you ever have somebody that comes in with posterior circulation symptoms and that kind of story, it's vertebral artery dissection until proven otherwise. Aw, forget it. We don't have time for all this. Uh, Lateral medullary stroke, Wallenberg syndrome. It's an interesting one. It's another brainstem syndrome where a very small lesion can have very profound effects. People feel very ill with this one. They have vertigo, nausea, all sorts of symptoms. Affects their swallow very badly, and all from a little tiny thing like this. So this used to be referred to as Wallenberg syndrome. There's Wallenberg. Try to stay away from eponyms nowadays. So lateral medullary syndrome is what we usually refer to it as. Try to stay away from eponyms because a lot of them were Nazis. Guess what, guys? I looked this guy up. His first name's Adolf. I was like, oh God. He's German, German Jew. We're okay. He was a German Jew. And actually, when the Nazi regime took power, he was forced out of his lab because he was a Jewish guy. And he came to America, lived in Illinois for about a year and died. And I learned that late last night. Wallenberg syndrome. The key point, the only thing you have to take away from this is if somebody has crossed symptoms, one side of their face and the opposite side of their body, that's a medullary problem. Two reasons. The cranial nerve tracts that go through there can cause ipsilateral and contralateral symptoms. The other thing is, where does the decussation occur for most of your nerve fibers? It's at the base of the brainstem. So if you get crossed symptoms, face on one side, rest of the body on the other, you're going to localize that to the medulla. Soapbox, again, vertigo is not a symptom. Vertigo is a symptom. It's not a diagnosis. So you don't diagnose somebody with vertigo. If you have to see a person every day for vertigo like I have to, at some point this starts to sound as dumb as like Mark sees a patient in clinic. Sorry, Mark. He comes in, he says, this patient is closing up their larynx and forcefully expelling air through it, and I diagnosed them with cough. That's what it sounds like to me. It's like, yeah, no, they have cough. Their symptom is cough. Vertigo is a sensation of movement even though a patient is not moving. Keep it as simple as that. It's not always spinning. It's usually spinning. It could be a boat-like sensation. It could be a tumbling. But it's a symptom they have, and then the diagnosis has to be something else. Skipping. Spinal cord ischemia, we don't see that much. I don't know why we don't see it more than we do. The blood supply to the spinal cord is impressively diminutive. It looks fragile. If you've seen it on a cadaver, you just wonder why we don't see spinal cord strokes every day. The tenuous part of the spinal cord circulation is anteriorly because it's supplied by the anterior spinal artery, which is right here. It's very small. And a lot of the important stuff within the spinal cord happens anteriorly. In these pictures, I have what's classic signs of spinal cord ischemia. They call it owl's eyes. And just so you know, if you're looking at diagrams of the brainstem, they usually display them in the classic sort of gross specimen sense, where they're upside down compared to what the MRI or CT images are. So these look upside down. In the posterior part of the cord, you probably remember the posterior columns and vibratory sensation and proprioception. Well, all the rest of the important stuff happens anteriorly. So over here on the right is a person. They're trying to depict here that this is somebody that's had spinal cord ischemia and they have motor deficits and impairment to temperature and pain, but they would still have retained some proprioception and some vibratory sensation, which makes for this person's subjective experience to be very strange. Things just feel weird. And they can still experience pain, even though they might not be able to feel other symptoms. It's just a weird situation, but it's characterized by paralysis. It's bad. Somatotopic funneling is something I completely made up. I made this up. But I just want to make a point here that when you look at these pictures over here, this is a lot of tissue involved in a right MCA territory. This is a periventricular stroke, and this is a stroke down in the posterior limb of the internal capsule. And a person's deficits with each one of these three different pictures could look identical. They could look severe and identical. And that's because everything that happens out here on the wrinkly surface of the brain gets funneled down through these tracks until it gets smaller and smaller until you're exiting the base of your skull, with something that's the spinal cord is not much wider than my finger. So little lesions, if they hit the right spot in deep tissue, can cause very profound deficits. Watershed strokes, we're almost done, I promise. All things being equal, if you could take all the flow of blood to the brain and gradually turn it down, if you had some sort of valve and you could turn it down. It turns out the first sort of cortical tissue that would become ischemic is the one that's at the distalmost tiny little branches of a major arterial territory. And there are places where these come together, like the MCA and ACA territory, and you're going to get a predilection for ischemia between those two. So this would be an example of that. It can happen in other places as well. When you see this sort of pattern, this is the carotid until proven otherwise. Why? Because the carotid is what the MCA and the ACA share. So that would be a great way to get a watershed ischemia there. Embolic stroke was not the point of today's talk, but just know it's very common. I didn't talk about it much because it wasn't the point today, but we see it all the time. And then all bets are off because you can get different lesions in different vascular territories. We already talked about the fetal PCA. When we look at an MRI, we're not just trying to determine whether or not stroke occurred. We can actually look at the pattern of ischemia and try to get a guess for what the etiology was. That's my point here. The way these look on imaging matters. And then I think I close with, my favorite thing. Franklin Delano Roosevelt, one of our presidents, 4 terms in office, 1933 to 1945. Here's a neurology tangent for you. This is called the unfinished portrait of FDR. It was April 12th, 1945. It was lunchtime. He sat for this painting. A woman named Elizabeth Shumatoff was painting him. It's a watercolor. And why does it look unfinished? Because as he was sitting there for that painting, there was a photograph snapped at this time too. He said, "I have a terrific pain in the back of my head." And then he went unconscious, slumped forward. He had a massive hemorrhagic stroke. He died same day. So neurology. She later, supposedly from memory, did this, which is how this was intended to look. She changed the tie color to blue from red. But yeah, this is a pretty famous presidential portrait called the Unfinished Portrait of FDR. Very interesting time in history. He was the president through the Great Depression and then through most of World War II up till almost the end of it. He dies April 12th. Victory in Europe Day was May 8th. The Nazis surrendered. And then we had to take care of things in the Pacific Theater, which, led to the bombing of Hiroshima and Nagasaki in August. And then victory over Japan Day. The war is over. September 2nd. All this stuff happened within 6 months. What a time to be alive. And it all happened because of a hemorrhagic stroke. No, I'm just kidding. But yeah. Any questions about anything I talked about today? Thank you very much. I don't know how to stop it. Okay. Fine.
Did you have a nice holiday?
Yeah.